Well, good morning, everybody. Thank you for being with us bright and early. My name is Dr. Mark Munier. I'm a general pediatrician and one of the co-directors of the Illinois DocAssist program housed at the University of Illinois in Chicago. And we're really happy to have you here with us for this webinar this morning that's going to be covering evidence-based psychotropic interventions in autism spectrum disorder, with a particular focus on FDA-indicated medications and the hot topic of the day, leucovorin, which people have all been clamoring about. So we're excited to have a fantastic team of 3 of our child psychiatry consultants from the Illinois DocAssist program that will be leading that content. The next slide, please. We have no disclosures. Just to let everybody know, we are funded, the Illinois DocAssist program, by the Department of Healthcare and Family Services here within the state of Illinois. Next slide. Here are our learning objectives for the day. We're going to review the common clinical presentations of autism spectrum disorder, just so we're all on the same page about that. Identifying FDA-approved medications for youth with autism. Also learning about when to consider off-label medications, and then, as mentioned previously, a specific focus on leucovorin and what the literature says about it. Before we jump into the content of the talk, just a quick overview on DocAssist for those of you who may not be familiar. So DocAssist is a free statewide telephonic psychiatric consultation service that is available to Illinois providers to help increase their knowledge and confidence in diagnosing and managing mild to moderate mental health conditions in both pediatric patients as well as perinatal patients. This is a talk mostly focused on children, but just to let everyone know, we do provide services for those who are working with perinatal patients. And as previously mentioned, we are funded by the Department of Healthcare and Family Services, and the program is operated out of the University of Illinois College of Medicine in Chicago in the departments of medicine and psychiatry. So the way that we accomplish that goal of increasing confidence across the state with providers is through 3 main ways. One is probably the most common thing that people think about with Illinois DocAssist is psychiatric phone consultation, where providers across the state can call in and connect with a child and adolescent psychiatrist or perinatal psychiatrist to talk about a concern that they have around a patient case. This can be everything from screening and diagnosis to treatment and management of mental health conditions. These can be very specific consultation questions that you have, or a more general sort of broad question around approaching children's mental health. And no PHI is shared. So this is a direct consultation between the clinician and the psychiatric consultant. The second way in which we do this is through referral assistance. We have social workers on the team that help provide vetted resources and referral information that may be of use to you and for your patients. Referrals can include everything from kind of looking for therapy options in the communities where your patients live, or psychiatric services, other things like inpatient programs, as well as partial hospitalization programs, school-related advocacy and legal resources, or other things related to early childhood mental health. And the last one, which is relevant for what we're doing today, is we really want to provide high quality education for providers across the state so they feel more comfortable starting to have these conversations around diagnosis and management of conditions in children and perinatal patients. So we do live webinars and conferences or invited presentations to specific practices. We do newsletters, and we also have a lot of online resources and tools that can be found on our website. And there is a QR code there if you have your phone with you and you are not yet registered with DocAssist. This is a new feature that we started in the late part of last year, where we do ask people to register for DocAssist, particularly if we're requesting a consultation, but also to keep you in the loop on all of our newsletters, webinars, educational events, etc. I will also put in the chat a link to this if you don't have your phone with you, or you're driving or something and you want to do that later. We would really appreciate you giving us that information. Next slide. This is how a consultation works. Just very briefly, you register, you request a consultation either online through your consultation request, or you can make a phone call. You pick a time to talk to your consultant, you discuss the case, develop a treatment plan, follow up, etc. Most consultations can happen within 30 minutes of the request of that consultation, if that's what you're looking to do, or it could be scheduled out to a day or time that is most convenient to you, when it works for your administrative time in your practice, or when you might have available time. The office hours are from 9 to 5. And then the thing that we always like to point out is that this is not a crisis line. So this is not for urgent cases that you're concerned about. There should be other protocols you have in place at your practice to handle that. But for other cases, we are welcome to take those consultation requests. Next slide. And then the last one for me is just our next webinar, just to let you know, we have the next one queued up. You'll be getting emails about this, especially if you register, this will come out. This is going to be delivered by one of our social work consultants, and it's going to be around exposure therapy for children with anxiety. So we think that's going to be a really fantastic thing where you can learn skills to practice in your office and how to talk with families about that. We are going to rotate times when we do these, since we know that people have variable times when they're available, but we'll record all webinars and get those sent out to you as well. And with that, I'm going to turn over to start the actual content of the presentation to one of our child and adolescent consultants, and that's Dr. Kelley Volpe.
Good morning. My name is Kelley Volpe. I'm one of the child psychiatrists here with DocAssist, and I'm just going to jump right in and start talking about what is autism spectrum disorder and give some context as we continue on the conversation about diagnosis and treatment. So autism spectrum disorder is a neurodevelopmental condition that is defined by differences in social communication and patterns of behavior. And it's one of the important things is that autism spectrum disorder is behaviorally defined, so symptom defined rather than caused by a single gene or mechanism. And so it's really important to understand that there's a lot of heterogeneity. Most kids with autism will look very different from one another in the different language, cognition, and functioning. And it's also important to know, like most neurodevelopmental conditions, that autism emerges in early childhood and is a lifelong condition. And it can present differently even in an individual over time. And so the DSM-5 TR has a diagnostic framework that we use to diagnose autism spectrum disorder, and it requires deficits in 2 domains, so both domains of social communication and restrictive and repetitive behaviors. And in order to meet criteria, all 3 aspects of social communication must be effective, and at least 2 types of restrictive or repetitive behaviors must be present. Symptoms do need to begin early in development, and even if they become more apparent later on when social demands increase, there still should be symptoms early on. And the diagnosis is based on functional impairment, not just presence of traits. So the traits, the symptoms have to impair how someone functions and interacts in the world. I should be saying to move slides. Thank you. So the DSM includes severity levels, which is it describes the amount that one can assign a severity level to the diagnosis for ASD, and it is meant to describe the amount of support that someone needs. It doesn't really confer a prognosis or intelligence, but the levels are determined just by how much support is required. So for social communication and behavioral flexibility in daily life. Each symptom category, so social communication, restricted repetitive behaviors, is assigned a level independently of the other, but there is no overall severity. So there is no autism spectrum disorder level 1, 2, or 3. The way instead it is for each individual subset, each individual category. So level 1 is requiring support, and these children who are level 1 often, if it's for social communication, level 1 will look like there's fluent language, average cognition skills, but they may struggle with social reciprocity, organization, flexibility, and without support, their difficulties, they may be less obvious early on, but become more apparent later, especially in school or social settings. Level 2 children at this level in the social communication range factor will need more support and have more noticeable social communication deficits. They also, for repetitive behaviors, the behaviors may be more frequent or more disruptive. And they require often more structured support. Level 3 is children who require very substantial support in the social communication category. This might be severe impairment, like being nonverbal, and in the behavioral symptom category, there might be significant rigidity And there's minimal verbal communication, marked sensory sensitivity. And it's another area that is important to know is that the severity may change over time. And like I mentioned, it doesn't refer to intellectual ability. If there are cognitive impairments, that is diagnosed by giving a specifier, such as with or without accompanying intellectual disability, or by adding the comorbid intellectual disability diagnosis. The current prevalence estimates, oh, yes, next slide. This one, yeah. Current prevalence estimates that around 1 to 2% of the population. ASD is diagnosed more often in males, but there's increasing awareness that females may be underdiagnosed due to different presentations or maskings. It's also important, like I said, it's very heterogeneous, so developmental trajectories may vary widely. Some children make significant gains with early intervention, while others continue to require support lifelong. And increasingly, we are recognizing and diagnosing autism spectrum disorders in adolescents and adults that maybe were not recognized at a younger age. Next slide, please. Beyond the DSM criteria, children with ASD often present with a range of associated features that pediatricians you all see every day. The language skills range widely from minimally verbal children to those who are fluent but with pragmatic language difficulties. There can be sensitivities, sensory sensitivities, rigidity, difficulty with transitions. These are very common. Associated features for children with autism spectrum disorder. Emotion regulation challenges and anxiety often emerge as children get older and demands increase. And so these are clinical features that we see with kids who are diagnosed with autism spectrum disorder. Next, I guess. There are also a high rate of psychiatric and medical comorbidities. Most kids with autism spectrum disorder have a psychiatric or medical comorbidity. It tends to be the rule rather than the exception. ADHD and anxiety, especially social anxiety disorder, are very common. Mood symptoms, intellectual disability. Medically, there can be sleep problems, GI symptoms, seizure disorders, and feeding difficulties. These conditions all occur at a higher rate in children with autism spectrum disorder than in the general population. And it is important to recognize and treat the comorbidities because it really can improve quality of life. Next slide. Something that we see something that we do see in children with autism spectrum disorder and is often a presenting problem of concern is irritability and aggression. And this is the irritability and aggression are not necessarily part of the diagnostic criteria for autism spectrum disorder, but they are very common in clinical practice, and they're typically driven by underlying features. So maybe communication frustration, sensory overload, comorbid anxiety disorder, the behavioral inflexibility, so changes in routine and irritability related to that, comorbid ADHD or mood disorders. So it's the management of irritability, aggression, and ASD begins with looking for those underlying contexts, identifying triggers, and using behavioral strategies. Medications are typically reserved in the second-line treatment for more severe or persistent cases. Next slide. Because ASD is so heterogeneous, there's no single evaluation or treatment that fits every child. And it's really important that the pediatricians are playing a key role in early identification, referral, and longitudinal monitoring, and ongoing identification and assessment as children develop over time. And so the assessment should be developmentally informed and multidisciplinary. And it's important to remember to address those comorbidities or features that are problematic, such as sleep problems, anxiety, ADHD. This can be just as impactful as an autism-specific intervention. And early identification and longitudinal support are really one of the ways that pediatricians make a big difference for kids who have, and their families who have autism spectrum disorder. Next slide, please. I just also briefly wanted to go into some screening tools. Many of them are free and many of them are available through our DocAssist website. The MChat is one of the most widely used ASD screening tools in primary care. It can be as you all know, administered routinely. The SCQ, the social communication questionnaire, is a very helpful screener for ASD and is very useful for older children. It uses a parent report. It is a licensed form, however, so that does kind of limit its utility. All of these screening forms are meant to indicate a need for referral for further testing. Often further testing will go on to use diagnostic tools like the ADOS or ADI that are specialist administered. And so it can be a helpful process for families to understand, okay, this screen was positive. The next step is to go through one of these full evaluations. And next slide. And then finally, I wanted to also mention some tools that can be used over time for assessment and symptom monitoring. As I mentioned, the core features and associated symptoms of ASD can evolve over time as children's lives change, they develop, there's more demand. And so using tools such as these, so the ADCI can help identify or look specifically at aggression and irritability. The Vanderbilts are helpful for children with ASD, just like for children without ASD, to assess for ADHD. There are broadband tools, some that are commonly used like the ASQ, PSC, the CBCL, or that can help identify comorbid diagnosis, even for kids who have autism spectrum disorder, just like typically developing kids. And so it's important to continue to assess for the comorbidities because, as I mentioned, addressing and treating comorbidities can have a large impact on quality of life. And these are my references. And I'm going to turn it over to talk more about the treatment to Dr. Lillig.
Good morning, everyone. Can you all hear me okay? Okay. So as Kelley said, my name is Mathias Lillig, and I'm a child psychiatrist with Illinois DocAssist. And in this part of the presentation, we'll talk about medication treatment in the context of ASD. One thing to keep in mind is that for the core symptoms of autism, there are no FDA-approved medications. And by core symptoms, just referring to parts of Kelley's segment, I mean the persistent deficits in social communication, the deficits in interaction, as well as restricted repetitive patterns of behavior or of interests, that there are no FDA-approved medications for those core symptoms. Where medication can be useful is when there are persistent mood symptoms or persistent behavioral concerns. And I want to emphasize that medication can be useful because in many cases, mood concerns or behavioral concerns can be addressed via other methods. If there are mood or behavioral concerns, it's very important to, number one, assess for and treat any underlying medical conditions. Number two, assess for and treat comorbidities. For example, ADHD, anxiety disorders, mood disorders, OCD. If there's no medical condition or no comorbid psychiatric condition, then it might be time to consider treatment of target symptoms. So in terms of target symptoms, Kelley had referred to irritability, and that's often the target symptom that people want to treat. And when the word irritability is used in the context of ASD, usually people are referring to external manifestations like temper tantrums, discernible changes in moods, and especially to aggression to others or to deliberate self-injury behaviors. And as Kelley had alluded to, there can be many influences leading to the manifestation of target symptoms. And so when there are target symptoms, before using medication, there should be attempts to understand what these symptoms are exactly and the reasons behind those symptoms. And it can be very helpful to analyze the symptoms and understand what contexts they're occurring in, what's happening before the symptoms occur, what's happening in the environment while they're occurring, how are people responding to the symptoms, are all questions that should be considered before starting medication. In terms of possible influences on target symptoms, sometimes transitions or changes in the environment can lead to tantrums and mood symptoms. Similarly, sensory issues, sleep issues, social issues can lead to symptoms. And as we mentioned, physical symptoms, or physical pain, I should say, and comorbid psychiatric disorders can lead to tantrums and mood changes. And for many of these situations, behavioral interventions are often first line. And the importance of behavioral interventions has been addressed by the AAP. As many of you probably know, the AAP put out a clinical report in 2020 and reaffirmed it in 2025, emphasizing the importance of behavioral interventions in children with ASD and recommending consideration of medication if behavioral interventions were not sufficient. The most recent practice parameter from the ACAP, which is the American Academy of Child and Adolescent Psychiatry, was actually from a while ago. As you can see, it's from 2014. And this parameter emphasized the importance of knowing what we're treating if we're prescribing to a child with ASD, having a specific target symptom or a specific comorbid condition. So moving back to that concept of irritability, let's imagine that our assessment of target symptoms has been completed. They don't seem directly attributable to a medical issue. They don't seem directly attributable to a comorbid disorder or a specific concern. And let's also imagine that behavioral interventions have not been successful. And let's also imagine that these are specific target symptoms that are significant and impairing. Once again, these symptoms could include tantrums, quickly changing moods, aggression, or self-injury. At that point, it's probably time to start considering medication treatments. As you may know, there are two medications that are FDA approved to treat irritability in ASD, and those two medications are risperidone and aripiprazole. And while their FDA approval is to treat irritability, quote unquote, in the prescribing information, both medications get a little more specific. As you can see, they mention aggression, self-injurious behavior, tantrums, and quickly changing moods. And I've highlighted aggression and the references to self-injurious behavior because those are really often the symptoms that end up getting treated with medications. Risperidone is FDA approved for this purpose down to 5 years old, and that approval came out in 2006. And aripiprazole just mentions that it's approved for irritability associated with ASD in pediatric patients, but the trials leading to that approval were as young as 6 years old, and that approval came out in 2009. The dosing for risperidone is a little different based on weight. For patients who weigh less than 20 kilograms, the starting dose is 0.25 milligrams daily, and the target dose is 0.5 milligrams daily. And for patients weighing 20 kilograms or more, the recommended starting dose is 0.5 milligrams daily, and the target dose is 1 milligram daily. And the effective dose range is up to 3 milligrams daily. For aripiprazole, the recommended initial dose is 2 milligrams daily, and the recommended maintenance dose is 5 to 10 milligrams daily, with a maximum recommended dose of 15 milligrams daily. Risperidone and aripiprazole, both being second-generation antipsychotics, have a similar side effect profile. A common side effect of both medications would be weight gain. And other side effects include those listed on the slide. And it's very important to monitor weight, blood pressure, lipids, glucose, and HbA1c. Since this side effect profile is, or at least can be, far from benign, many of us don't end up starting treatment with antipsychotics unless the symptoms of irritability are really severe and impairing. For example, a child with ASD who's experiencing temper tantrums, let's say, but isn't aggressive or isn't self-injuring, we may not go the route of antipsychotic treatment immediately. In a case like that, we might consider using an off-label treatment like an alpha agonist as a first line. In terms of off-label medications, one question that's important to ask is, are the symptoms impairing enough to warrant an antipsychotic with a possibly significant side effect profile? Again, for example, temper tantrums without aggression, we'd ask ourselves, is that severe enough to warrant an antipsychotic with a possibly significant side effect profile? Another example might be self-injurious behavior that causes only a minor injury, like a callus, let's say, or no injury. And concern about possible side effects is certainly a reason to consider off-label medication. When it comes to off-label medication, as I mentioned before, alpha agonists are a common choice and may end up being first line in those situations where there's irritability, but it's irritability without aggression or without self-injury. Alpha agonists, as you may know, are often used in ADHD to treat impulsivity and hyperactivity. And the consideration for using them here is that they may help reduce the impulsivity that could be part of tantrums or other behaviors. In terms of alpha agonists, both guanfacine and clonidine are used, and both of those have immediate release preparations and extended release preparations. And some of the common dosing ranges are listed on the slide. Again, most importantly, alpha agonists have a more benign side effect profile than antipsychotics. They can be sedating. They can lower blood pressure. In more extreme cases, that can cause some lightheadedness, or in very extreme cases, even syncope. So monitoring blood pressure if someone's on an alpha agonist is important. So if risperidone, aripiprazole, and alpha agonists are not helpful, it's probably time to reassess the irritability and reconsider behavioral interventions and either refer or re-refer to child psychiatry. There are some less studied medication treatments out there for irritability and its attendant manifestations. Those other less studied medication treatments would include other antipsychotics, for example, ziprasidone or olanzapine. They would include mood stabilizers, and they would also include antidepressants. And I will hand it over to Dr. Romba.
Yes, thanks, Mathias. So we're going to transition a little bit now to talk about the topic of leucovorin. We'll start with what leucovorin is. Leucovorin is also known as folinic acid, which is a reduced or active form of folic acid. It's important because it can enter the folic acid metabolic pathway at a separate step. And you can see in the figure I highlighted where folinic acid enters the pathway versus folic acid itself. So when there is a condition, when a certain enzyme in that pathway is blocked, I'm referring specifically to DHFR, dihydrofolate reductase. I'll never say that again for the rest of the talk. If that's blocked by, like, let's say methotrexate, folinic acid can enter that pathway separately and still maintain levels of folate within the body. So folate's a very important medication, and it's very involved in DNA synthesis and cell growth, and often you'll see it used as a target in cancer treatment. So currently, what are the two FDA indications for leucovorin? The first is used as a rescue treatment for high-dose methotrexate therapy in adults and pediatrics patients that have a form of cancer, osteosarcoma. And the second indication is use in diminishing toxicity associated with something like methotrexate or other folic acid antagonists. So the purposes of use currently are really related to either methotrexate or some form of one of these two indications. So ongoing, there are some small preliminary studies in the world of leucovorin that have been looking at its use in certain conditions. So two of those I have mentioned here. One is cerebral folate deficiency, CFD, or in children with autism that have a very specific type of autoantibody of a folate receptor. That's referred to as FR alpha A, if that comes up again in future slides. So we're going to go into each of these in a little bit more detail, just so you have some understanding of both. So with cerebral folate deficiency, that means that there's low levels of folate within the cerebral spinal fluid. And this can be associated with autism-like features, developmental delay, seizures, spasticity, ataxia, and some of those social and communication deficits that we can see in autism often can appear in this condition. While it's mentioned in the literature, it's very difficult to diagnose. There's currently no standardized testing or agreed upon testing for CFD. It requires a lumbar puncture to analyze the CSF or genetic testing, neither of which is really a standard of care at this point in time. And then I also wanted to mention just a little bit about these folate autoantibodies that I had mentioned. This is a figure showing you what that receptor might look like on a cell, it's highlighted in blue. And the autoantibody is produced by the body and will attack that receptor so that folate can't enter into the cell. And that connects to having low levels of folate, either in the brain or spinal cord. And again, this is something we still don't know a lot about. There's no approved testing for these autoantibodies at this point in time. So I wanted to give you all an overview of some of the studies that are out there, some of these preliminary pilot studies looking into leucovorin use in children with autism. I think the best way I would like to summarize this is most of these studies are looking specifically at children with autism that have that autoantibody that we just spoke about. So these are not studies in general looking at children in general with ASD. It's really a specific subset that have that autoantibody. There's one RCT in this listing, RCT being a randomized control trial, and the others are case series, a single blinded study, and again, not an RCT. What some of these studies look at are outcome measures, specifically looking at verbal skills, communication skills, and adaptive skills. And then a few of them look at the CARS and the ADAS, which are other autism scales that are commonly used to assess functioning and symptoms. So based on this lineup of studies, the subjects that were treated with leucovorin who had that positive autoantibody type demonstrated improvement in language and social skills and in some communication abilities, which is why much of this has come up recently in discussions in the community and in circles. So I wanted to take a minute to think about how can we understand all that data and how can we synthesize that and what does that mean for clinical care. So all of the studies to date are very small. The total number of subjects is under 100 in each of those studies. There is not a randomized, large, multi-center study. And most of the studies that we mentioned have that specific autoantibody positive subtype. So the studies are not generalized across all children with autism. A very specific subpopulation of children with autism have been studied. So the AAP has kind of assessed that sort of data and has suggested that we really need to have more studies to look at whether these preliminary findings are reproducible and can we better understand the efficacy and safety of this kind of intervention in more children with autism because we don't have that level of data at this point in time. There's another concern that if we start to use a medication like leucovorin off-label, it might create shortages of the medication or increase cost of the medication, and potentially have shortages for the other indications that we discussed for use in cancer treatment. So just to make sure that we review what are the formal clinical recommendations on leucovorin at this time from the AAP. At this time, the AAP does not recommend the routine use of leucovorin for autistic children. And then from the Psychiatric Association, as well, very similar. Folinic acid has not been a recommended treatment for autism. It will require many more years of research before we know if leucovorin is an appropriate treatment for individuals with autism, just so that we capture sort of what the clinical consensus is at this point in time from these two bodies. But many of you that work in clinical care and educational settings might be asked this question by families of children with autism, and what can you share with them? What can you guide, and how can you have this conversation in a way that is data-based and meaningful? So you can consider this type of approach, so kind of a three-prong approach. Review that there is a current limited evidence base for the use of leucovorin for autism. And as we mentioned, some of the slides, the studies that we just reviewed on that one slide, we really need more wide-scale study, a larger multi-center study to really better examine this medication in the broader population of autism. And we need more safety guidance as well. And then you can guide families around what are the evidence-based treatments that Dr. Volpe and Dr. Lillig mentioned, and then engage, of course, in a meaningful conversation about what are the goals of the family, what are the target symptoms that are causing most impairment, what are the risks and benefits of any treatment, and then how do we make sure we're optimizing the first-line treatments that are still considered first-line. Okay. So I think we're gonna open it up and talk a little bit more as a group, I'm curious to hear from our audience today as well. So I might come off sharing so we can all kind of see each other, if that sounds good. And we can kind of proceed to discussion and question and answer.
Courtney, I'll just follow up. There's one question in the chat already about side effects of leucovorin, if you know about that, and what would be the downsides of taking it if parents did want to have their child on it.
Yeah, that's, I think, again, we just don't have a lot of information on that. I saw some comments about sedation and fatigue with use of leucovorin, but I think that the bigger concern is we haven't had a wide scale study to really look at what are the side effects. So we would have to go based on either these small studies or the studies where leucovorin is used with patients being treated with methotrexate, which is a different population, right, than children with autism. So we need more investigation of side effects and safety profile. And the other piece I'll put out there, we have no guidance on dosing, none whatsoever. There's no guidance from a mental health perspective. In psychiatry, we have absolutely no guidance on where you would start, how you would titrate. Some of these preliminary studies you can read yourself and kind of look at their dosing parameters, but there are some, I would say, different thinking schools of thought on whether you use low dose or high dose. And again, we don't have the answer to those questions.
I'll just kind of keep reading maybe some of the questions in the chat that are coming up. There are some families that are asking for genetic testing for folate deficiency, thinking that could help be an indication for them to use leucovorin. Any comments?
Yeah, we still don't have standard of care recommendations around MTHFR testing. You can get some of that with some of the pharmacogenetic companies that are out there, but we still don't have any sort of formal study looking at the utility of that. And you will see in practice, some people will say, let's supplement with folate if you have this deficiency, but we don't know how that connects to clinical outcomes for behavioral management for autism or for mood disorders at this point in time.
Question here. I don't know if you can see the questions too, panel.
Yeah, I'm looking at this. I will say to myself, and I'll ask my colleagues, I do not know what Falopro is, so I really can't give guidance on Falopro. Maybe who asked that question could share a little bit. I'm curious if there is anything about that you would like to share with the group, or if you have some background yourself with Falopro. And just in general, I will just say, again, going back to pharmacogenomic testing in general, you may see people obtaining these tests here or there, particularly if a child is non-responsive to medication. I'm talking about beyond autism, just children in general who are on some type of psychotropic. Again, don't have that as a standard of care practice. So it might be being done, but it's not part of formal treatment guidelines at this point in time. So we really can't give specific guidance around any sort of pharmacogenomic testing based on what we know right now.
I was going to ask a question to Mathias, maybe off the leucovorin topic. When you talked about the antipsychotics and you gave the starting dose and the kind of goal dose, what is the sort of recommendation on how quickly you titrate up to that recommended dose? Obviously, you'd be following symptoms, but how quickly do you do that?
That's a really good question. Thank you, Mark. The rule of thumb when titrating one of the antipsychotics in this context would be to wait at least 2 weeks before going up on the dosing. One of the goals, of course, is to use the lowest effective dose. And without giving a couple of weeks, it's hard to know if that initial dose or that lower dose would be effective or not.
Great, thanks.
And I'll respond to the last question about kind of concern about families, right? And hearing all this information in different types of information, right? From what we might be saying in the medical community versus what might be elsewhere. And so the AAP has a wonderful FAQ, specifically about leucovorin, the limitations of leucovorin, what the existing data shows, and an FAQ that is really, I think, great for yourself and also to review with parents. I think it's right to the point, and I think it provides a good summary. So I would suggest if you're looking for some resource, that would be a great place to start with the AAP and their FAQs on leucovorin. And then I see a question about guanfacine dosing at nighttime. Mathias, I don't know if you wanted to comment on guanfacine dosing.
Sure. Yes, and when guanfacine is prescribed, it is most common to start with nighttime dosing, and that's because it's very hard to predict if a child is going to feel very tired or sedated on an alpha agonist, and so if the initial dosing happens at night, if the child does feel sedated or feels very tired, that ideally they'd be going to bed shortly anyway. And while I've got the microphone, I was going to mention just in terms of resources for parents, this is a few years old, so it doesn't have all of the recent information on leucovorin. But a few years ago, the American Academy of Child and Adolescent Psychiatry, I think in conjunction with the American Psychiatric Association, put out a parents' medication guide, specifically about ASD. And that would be a good summary of information about medications used in ASD up until the point when it came out. And again, unfortunately, it's not very recent. I think it came out maybe 7 or 8 years ago. But that should be available online and free. And that's, as I said, put out by ACAP and APA. And so it's backed by the two main psychiatric professional associations that we have.
Sorry for the super long link, but I just put in a link also to the Healthy Children, which is the parent-facing AAP parent education page that has a section on kind of generally about autism, but there is a mention around leucovorin in there. Full disclosure, I've not read the whole page, but I tend to use Healthy Children for lots of parent education of a variety of conditions. So you might want to look that over as well.
And inspired by Mark, I put in the link for the ACAP and APA Parents Medication Guide for Autism Spectrum Disorder.
I see a question also about the side effect of weight gain in antipsychotics and how to address that common side effect.
Yes, that is a dilemma that comes up in clinical care fairly often because we um, we can certainly see situations where an antipsychotic might be effective in terms of reducing irritability, reducing aggression, reducing deliberate self-injury, but those side effects that we mentioned are occurring. And so it can be a real dilemma in terms of, do we continue this antipsychotic in the face of significant weight gain, or do we try to taper and discontinue the antipsychotic, running the risk that there will be a return of irritability and maybe aggression and self-injury. And so in those cases, the standard way forward would be to do a lot of communication and psychoeducation to the child and family about things that maybe they could try to mitigate the weight gain. For example, if there are changes in nutrition that could occur, if there are changes in activity level that could occur. Sometimes families can be very good about implementing those possible changes and even making it sort of a family effort to change the way that they're eating or change their collective activity level as ways of mitigating the child's weight gain. If those efforts don't work, sometimes we try to taper the dose of the antipsychotic to see if that can prevent or reduce weight gain, but it is a struggle. I would say also that sometimes, especially in the context of children who are a little bit older, sometimes metformin can be started as a way of minimizing weight gain. And I'm not sure how many of you are psychiatric providers versus primary care providers, but when metformin is recommended by a psychiatrist, usually there's a lot of collaboration with the primary care provider about whether that's an appropriate medication for that child. And oftentimes for a young person, the primary care provider would prescribe and manage that metformin rather than the psychiatrist.
Mathias, while you're on that topic, there's a question around how often would you check labs when patients are on antipsychotics, the labs that you mentioned?
Yes. If possible, I know it's not always possible because sometimes obtaining labs in a young person is very difficult. If it's possible to even get pre-treatment labs, that can help identify whether there are increases in lipids or in HbA1c with the antipsychotic. Sometimes that's not possible. And if it's not possible, there are different recommendations and different from different sources about how often to get labs. It would be common to try to get labs within 3 months or so of starting the antipsychotic if one cannot get pre-treatment labs. If the labs are normal, it becomes the standard would be to get them yearly. But if they're not within normal limits, it would be more common to get them every 6 months.
And this one might be for you, Courtney, but is there any subset of patients with ASD for which you consider empirically trying leucovorin?
Yeah, it's a great question. But we at this point in time, as the AAP and APA mentioned, there just is not enough guidance, safety data, or evidence to for the use of leucovorin. And so I don't think there's any subset of population, even at this point in time, that we have enough data on to make such recommendations or give any guidance related to that.
Another question here for you, Mathias, and this has happened to me, so I'm curious your answer as well. That Aaron Hickey put here is, can you speak to managing asymptomatic hyperprolactinemia in a patient who's responding positively to risperidone, but does have that lab finding? At what point would you consider switching medications or continuing course?
Yeah, that's a really good question, and that does come up clinically. So there's some literature that proposes clinical guidelines for hyperprolactinemia. And in the case of asymptomatic hyperprolactinemia, they kind of break it down into what's mild and moderate and severe. And mild would be considered below 50, and I think the unit would be nanograms per milliliter. And so for asymptomatic mild prolactinemia, the recommendation would be to continue monitoring, but I don't think there's a specific recommendation in terms of how often you would monitor. Moderate hyperprolactinemia would be considered 50 to 100 nanograms per milliliter. And when the hyperprolactinemia reaches that range, typically there would be a change in the antipsychotic. It would be only if it's mild and asymptomatic that people would typically continue the risperidone, but with ongoing monitoring. And with hyperprolactinemia, as all of you may know better than I, the typical recommendation is to get an MRI just in case there's a prolactin secreting tumor.
And Mathias, one other thing I would mention on that, obtaining prolactin levels as a standard of practice with antipsychotics, that's really not part of the treatment guideline. That's not part of the labs that we monitor, right, as part of those baseline 3-month annual labs. Just to clarify, and we get our routine screening labs, that's typically fasting labs, glucose and lipids, just so everyone, so where prolactin shouldn't be ordered routinely unless you have concern clinically. And that's a helpful comment. Thank you, Prudence. Prudence, it's interesting to hear. It sounds like you have a lot of families that have shared with you some feedback about their experience with leucovorin. So thank you for sharing anecdotally what you've heard.
And if there's time for one more, Andrea had asked about experience with stimulants with youth with severe aggression and impulsivity presentations. Sounds like she's had some more negative experience in terms of increased agitation than expected. So just curious about research or experiences.
I think anecdotally, with children with ASD, we do tend to see in general more sensitivity to medications and to adverse effects. So I do wonder, when we see this sort of reaction with a child with ASD with increased irritability or increased aggression on stimulants, we do tend to see more sensitivity. And so that might also just be something to keep in mind when you are thinking about medication management. Right, start low, go slow is always a good rule of thumb, especially with stimulants with a child that might be more med sensitive. As for specific literature around stimulants specifically in ASD, I really can't kind of speak to that right now at this point in time. But I would say anecdotally, certainly we have a lot of patterns of this that we see clinically with sensitivity to the side effect profile of stimulants in ASD.
I'm just going to say, I know we're wrapping up close on time. I'm going to put one more time in the chat our registration. I think all the questions we've been getting have been fantastic examples of the types of consultations that you could request through Illinois DocAssist if you're treating a patient and have questions that you want to get expert opinions on. So I think consider this your first sort of test run of like what a consultation might look like if you had that. And again, please register for our to be part of the DocAssist program so you can continue to get updates on educational programs that are upcoming, including our webinar that we mentioned will be towards the end of February on exposure therapy for patients with anxiety. We're always open to feedback as well on things that you're interested in hearing about or ways we can improve. So we'd love that as well. Looks like we're about 3 minutes shy of the end. I don't know if people want to stay on, if there's any other burning questions. And as was put in the chat as well, Rhapsody, who is our fantastic program director of the Illinois DocAssist program, she will be sending out to anybody who participated in the webinar or registered a recording as well as the slides. So you will have those available to you. And all right, well, I guess people feel like calling it a day, not a day. Anyway, well, thank you everyone for joining us. Thanks to our fantastic panelists, 3 of our DocAssist child and adolescent psychiatrists. There are 2 additional ones. We have a total of 5. So if you call in, you may be fortunate enough to speak with one of these 3 fantastic doctors. So thanks so much for joining us, and hopefully we'll see you next month on our next webinar focused on therapy options.
Okay. Thanks, everybody.